Yinka, should we just get started and would that be okay? Well, we get through into the introductions. How about if we start with that?
Yeah, that sounds good.
Okay, very good. Well, good afternoon, everyone. Um, Excited to welcome you to the new year DRISS Presents TEACH-Recruitment Science seminar series. If you're new to our seminar series, just an FYI, we offer this series monthly around this lunchtime, noon to 1. Thank you for putting that link in, Molly or Kathy. I'm not sure who did that, but the seminar series is open to everyone and also can be used for the Implementation Science and Community Health Outcomes Certificate that we have here at ICTR. So I'm just going to give you a brief introduction to our amazing panel that's going to be presenting today. Really excited to hear this work that Dr. Yinka is doing with her community partners. So Dr. Olayinka Shiyanbola is a professor at the Charles R. Walgreen Jr. School of Pharmacy, Department of Clinical Pharmacy at the University of Michigan. Many of you may know Yinka because she was a former professor here at UW-Madison, who we sadly miss her presence here on our campus. So we're really excited to have her presenting today. With Yinka today is Sherry Perez-Torres. She's from the Community Health and Research. She's a Community Health and Research Program Coordinator at the United Community Center in Milwaukee. UCC is a large Latino nonprofit organization that was established in 1970, provides a variety of educational, health, and social service programs to the Milwaukee area Latino community. As part of the Health Research Department, she works to facilitate community health research projects, activities, and programs that promote the physical and mental well-being of Hispanics and community residents to reduce or eliminate inequities in the health and wellness of Latinos and the community. Sherry serves on the Wisconsin Public Health Council, is a member of the Milwaukee Latino Health Coalition, and is co-chair of the MLHC Research Action Committee. In addition, Sherry serves as the Community Advisory Board member on different research projects in Milwaukee, including the All of Us Research Program. Sherry is currently working on her doctorate of public health at Milwaukee College of Wisconsin and has a master's degree in public health from the University of Puerto Rico Medical Sciences campus and a bachelor's degree in biology from the University of Puerto Rico at the Rico campus, or Rio campus, sorry. And is Delicia with us? She in? Yay! Delicia Morris is a research specialist in the UW-Madison School of Pharmacy. So I am really excited to hear this presentation by Dr. Yinka and her team on enhancing diabetes management with pharmacists and community health workers. So I'm going to turn it over, Yinka, to you and your team.
Thank you so much for that kind introduction and for giving us space to be able to be here and talk a little bit about ENRxICH. As we were planning this presentation, one of the things we want to do is to try to make it as informal as much as possible. We just have a few slides to share just to give background information and give a little bit of context about the work that we are currently doing in Milwaukee. And as much as possible, we want people to be able to ask us questions and we are all yet to learn from each other as well, because that is what community engagement is about. It's about that bi-directional communication. So I will start off with the very first slide, as you see. So ENRxICH is, as you see, the title is called Enhancing Diabetes Management with Pharmacists and Community Healthcare Workers. And ENRxICH is currently an NIDDK-funded R01 trial that is being conducted in Milwaukee in partnership with different community organizations, UCC, of course, being one of them, Center for Community Engagement and Health Partnership with Dr. Gina Green-Harris Group. And this work is based on a lot of the pilot work that I had done, trying to understand how to improve pharmacy-related care for managing diabetes among Black and African-American adults, but now thinking about also our Hispanic adults. So ENRICH is a randomized control trial, and I'll tell you a little bit more about the different groups that we've included in our study. But the idea of the ENRICH trial was around the idea that for Black and Hispanic adults, it's hard for them to be able to manage diabetes. We already know that diabetes complications, a lot of disease, the disease prevalence of diabetes is at least twice more likely among this group. And sometimes these marginalized groups just don't have the right information. They don't know who to ask that information, and yet they just don't know where to start when it comes to managing diabetes. And we've also seen from a lot of our prior work that Black and African American and Hispanic adults, they are less likely to take their diabetes medicines. And beyond not just taking medicines, they are usually affected by life challenges that impacts diabetes care and impacts the enhancement of and their ability to be able to self-manage diabetes on their own. And so it's not just those life challenges. We also know that when it comes to health beliefs and perceptions about diabetes and medicines, they are influenced by what they know and believe. And so the whole premise of the ENRICH trial is to how do we address health misperceptions around diabetes and diabetes medications? How do we improve pharmacy-related care? And I'll talk a little bit more about that. And then how do we effectively address life challenges that might impact diabetes care? And now, make sure my slide is advancing. Oh, okay, there we go. And so the ENRICH trial, as I mentioned, is a randomized control trial. So when individuals are enrolled and screened, and we'll have the team members talk a little bit more about our community-based screening approaches, they are randomized into 4 different groups. And the first group is the group 1, which we call our blue group. And this is the group that continues their regular visits. They continue their interactions that they have with their pharmacist. They can go to whatever pharmacy they have been going to prior to the trial. And this is important for us to maintain that usual care. And from group 2, which is our green group, these individuals who receive what we call medication therapy management. So what that means is they are receiving support, additional support from their pharmacist on how to manage their diabetes medications. So for example, they do a medication review, they are talking to them about how to address their side effects. In some cases where they recommend a different prescription medication that might be better for their management, they're able to reach out to the healthcare provider to also communicate about possible changes, and also think about maybe doses need to be changed, or maybe a better prescription is right for them. And then we have our purple group, which is our group 3, which then receives support from a community healthcare worker. We have a team of community healthcare workers that we work with. It was very important for us in our community engaged approach to have individuals who speak both speak English and also speak Spanish. And so that way they're able to tailor their communication also based on language preferences. And they spend a lot of time addressing social determinants of health issues. They're talking to them over the phone about also addressing these health misperceptions as well. And then we have a group 4, which is our final group that then gets it all, which means they are also talking to the pharmacist and also at the same time talking to the community healthcare worker. And our hypothesis is that at the end of a 6-month intervention, we want to know which of this group has better care when it comes to reducing their hemoglobin A1C. And also, we're also doing a little bit of a cost analysis as well to think about policy implications, because it's not just receiving better care for clinical effectiveness, but how much does it really cost the healthcare system if it turns out that group 4 is the group that is that we got better effectiveness of the intervention. And then the last slide that I'm going to share is an example of what we walk our participants through when they come into the screening process. One of the things that our team has focused on is in increasing transparency and trust within the populations that we work with. And we already know from the data that many of the populations, marginalized groups, they most of the times don't know about clinical trials and they don't have enough information about clinical trials. So this is an example of a video, information in a video that we show them during our screening, where we show them all the steps that they need to take from the beginning of the session all the way to the end of the trial process. And so we show them using graphics, as you can see, using an infographic. This is where you are. You are right now screening for an A1C, and now you are doing this orientation to give you all the information you need about the trial. One key component is this happens before they sign the informed consent form. And the reason is because we want them to be able to make an well-informed decision about whether they participate in the trial. And then we walk them through even all the steps of you are going to be randomized. What does randomization mean? And then the video also shows them all the things that happens when they get randomized. We tell them about how much money they are going to receive. We are very transparent about that. Some of the things that we know is when it comes to participating, especially in behavioral clinical trials, it takes a lot of time. And so we are very transparent in how much time is it going to take you, depending on whether you receive the green intervention, 3.5 hours, the purple intervention, or the red intervention, or you are placed in the red group. And we tell them how much they're going to receive and how much time is going to take all the way to the end. And then it's not just the breaking down of how much money they're going to receive, but also the totality of how much they're going to get at the end of the study. Now, why is this critical for us to spell all this information out? Is because we want to improve transparency. We want to be accountable to the community that we care about when it comes to participating in a clinical trial and participating in research. And then at that point, they can ask us questions. And when they ask us questions about the time it's going to take, how much money I'm going to get, what does it mean to be in a green group versus a purple group? When those questions are answered, that is when we then tell them about signing the consent form. And I will have Shari and Delisha continue.
Thank you, Dr. Inka. Hello, everyone. So I'm going to describe here how we do the whole screening process. It is something that starts with an initial screening. That's something that Delisha, I do, and also some students help us with this. And it's basically calling the participants first and explaining about what we're doing in the project, why we're doing what we're doing, and what they can get in terms of what they can learn, the money, and all the experience overall. So that is the first point of contact with the participant. Delisha is going to talk about the recruitment strategies, but basically, once we have the phone number of the participant, we'll send them a text message just to see when is the best time to call them, to make sure that they know it's us and why are we calling, and for them to expect our call. So we do that, we call them, and when it's more convenient for them, it could be after hours, it could be a Saturday. We try to make sure that the patient or the participant feel comfortable when we call them, and we explain all the steps of what we want to do before committing to anything. And once they are interested in actually verifying if they qualify for the study through the A1C screening, that's where we set up an appointment with them and we ask them to come to the clinic to check the A1C. Before that, we do explain, hey, you only qualify if your A1C is 8 or above, because many of our participants already know what their A1C is. And if they're not sure or they think it has changed, that's when we give them the appointment just to check if they qualify. It's important for us to let them know that they will receive $10 because they are spending some time with us on the phone while we explain what the project is about. So they don't have to wait until they're enrolled in the study to receive some type of compensation. They will receive those $10 because they're taking up their time to talk to us. And once they come to the clinic, they will receive additional money because of that time that they will expend in the clinic. So that's the green point there, the A1C point of care test. That's where we test the A1C. And if they qualify, because we already screened everything else, that's where we tell them, yes, you qualify. And after that, we give them some videos. They can watch the videos, and I know Dr. Yinka mentioned some videos, but it's pre-orientation video that explain what research is about, what's the difference between research and clinical care, why we're doing this, and what they can expect. And they also watch a video about specific details of the project, which are included in the consent form. But as Dr. Yinka showed us, it is very important for our participants to understand what they're going to do, to understand all the steps. So that's why we showed them specific graphics where they can understand everything, and we are there ready to answer any questions that they might have. So once they watch the videos, they kind of get like a bigger and deeper sense of what they're going to be doing, and that's where we move to the consent form. And with the consent form, we stay there with the participant. We go over the consent form. We answer any questions that they might have. And once they're ready, we sign the consent form and they're part of the study. So that's where we ask them to complete a baseline survey. That baseline survey, it is long, but we let them know ahead of time that it's going to take time. So just let me know. We can be flexible. And then we have started to give them options. You can fill out the survey at home. We can give you some other options. We can call you if you need help. And that's how we make sure that we can collect all the data, but at the same time, allowing them to choose what's the best way of doing it in terms of their time and how comfortable they feel. And that's why all this process of checking their A1C, watching the videos and doing the consent form takes around 90 minutes if we do everything at the clinic that day. Most of the participants already know that they will be with us for approximately 90 minutes, so they're okay with it, but there's always options for our participants. And now Delisha will share with you some of the recruitment efforts that we've done.
So we've learned a lot from our recruitment efforts. We started off with our Hyatt Pharmacy invitation letters. And initially, I think we all thought that, yes, Hyatt is such a great partner. These letters are going to go to specifically the participants who qualify for our study, and their A1C is going to match, and this is going to be a breeze. And we end up learning that that was not the case, that some of the letters went to type 1, type 2, gestational, pre-diabetic patients. We learned that the letters went out to people of all different ethnicities. And so we got to meet a lot of different people and just learn the different needs of the diabetic community that's out there. And so we quickly realized we had to put in some more ways, and we had to elicit the community, and we asked a lot of questions like, how can we make this work? We ended up going to Calvary Baptist Church, and we had a nice conversation with their church members about who might want to be screened and who would want to join our study. And again, they enjoyed our presentation, but no one was jumping at jumping at the opportunity to join our study. They were like, that was really nice. And so again, we said, all right, we need to think of some other ways to engage with the community. So we started saying, let's get out into the community, let's get out into the neighborhoods. And we started to try to figure out, where were they holding community events? Where were organizations like-minded with health or education? People would be. And we, as you can see from the flyer, this is showing some of them. We were on the north side, we were on the south side, we were everywhere, meeting the people, trying to figure out what's the best places for us to be. One of the first places we went to was the Gathering from 98.3. And we learned very quickly, like, okay, we need to start being strategic about the events that we go to. If we go to an event where people are used to just having fun, they might not be as engaged with us as the people who want to learn about their health. Then we went to health events and we started learning, okay, all these people are coming, the screenings are going great, we're nice and busy. But we were finding out that all these people were so engaged in their health that they weren't quite qualifying with A1C. And so then it's been lots of pivoting to find out where is our audience. And so we had recently connected with the Mexican consulate, and we found out that being with them could be a special sauce of what we need to do, because being with the Mexican consulate, we have an organization, a group of people who know why we're there, why we're coming, and they are engaging with the audience to come to our screening. They understand why they're being screened. And it seemed that more often we were getting people that were hitting the A1C. I think another successful thing for us was our radio ads. When we start having ads on Jammin' 98.3 and The Truth, we end up getting so many people interested in A1C more often that was qualifying. So we have done a good job, I think, always engaging with the community about our study, always asking for advice from the community, our board members that surrounding these efforts. We are always trying to find different ways to improve recruitment and get more people into the study. And we've noticed that our word of mouth has also been very good, that people are telling people, even if they didn't qualify for the study, that we're not just out here trying to collect data, that we're really trying to help the community. So that's been really heartwarming for me to know that the efforts of our team is being told that these are nice people, these are genuine people, they care about your health, they want the community to be helpful, and they're sending us their siblings and their friends and their church members. So I have a good feeling that 2025 and beyond, we're going to get the ball rolling in just the right way.
And now I'm going to share about what we've done because of what we learned with the community and the challenges that we've been facing, and how we want to make sure that we can find people who can qualify for the study, who have their A1C 8 or above, uncontrolled diabetes, and they need that support. So we started to communicate with health systems who can actually look at their patients and see this patient is struggling with their diabetes. Their A1C is so high that they might benefit from the study. And that's how we've been able to connect with providers who could eventually refer participants to us. And that includes the Milwaukee Health Services, that includes the Aurora Healthcare Walker's Point Clinic, and the Outreach Community Health Centers. And the important part of this is that those health systems are in the community, are serving the community that we are trying to connect with. and are trusted health systems. So we needed to connect with them to be able to get to the audience that we are looking for. And some presentations were made to the providers, and they asked to, of course, you can drop off flyers and you can bring posters, and that way community members can start to look at your faces, look at the logo, identify and reach and feel more comfortable to participate. Additionally, a proposal was submitted so they can share the health records, basically the information that could help us identify the people that might qualify for the study and strategically connect with them. And of course, we're waiting on decisions from these health systems, but most of them are already in conversations, are saying yes to at least dropping up the flyers at their locations and sharing the information. So we are hopeful that this initiative and this strategic type of communication with the community will help us find the people that actually qualifies for the study.
So the difficulties that we faced, you know, I truly do believe that challenges just make you stronger. So one of the things was getting a hold of our participants over the phone, which has been so interesting because we've seen that challenge in a variety of different ways. The first way, which is understandable, is that people just don't want to answer their phone. And we were calling people during times where they were getting a lot of text and phone calls from so many different places due to the election, due to like Medicare, Medicaid updates. And people were feeling weary that we were fraudulent. And so, and then just fatigued with how many phone calls and text messages they were getting that they didn't want to even deal with another call. So one of the strategies was to move to using a system called Doximity, where when we're calling, it literally will say who we are and legitimize our phone call to them. So even though we could still have that challenge, at least we're taking the additional step to say, this is who we are. And to help with the amount of calls, we added on additional team members. One of the other difficulties with getting hold of participants over the phone is some of our participants are lower income. And so their phone numbers could change, as well as they might be using government phones where their minutes have ran out. So a phone number you may have used a month ago or 2 weeks ago may now be a different phone number, or you might even have to wait a while and use that same phone number again later to get a hold of a participant. So we've really had to be patient and learn from the community the best ways to communicate and how to do that. The other difficulties is that we have to have screening days based off of the availability of our team. And that doesn't necessarily match all the time with when people have availability. But I think we have done a very good job of when we're calling people and we're letting them know that we have a Thursday screening day. If we were out in the community, we'll say, hey, these are some of the other optional ways that you can meet up with us, that we're not just waiting for us to meet people in the community. When we're talking to participants, we're letting them know this is also an additional day that you can come and get your A1C done, because we know we've screened you and you qualify initially. So we were always thinking of ways on how to meet with people. Another thing that we've done is we've gone heavily with the people who are comfortable with using their cell phone or with technology, because that's not always the case. that we're trying to send them links where they can do as many things at home in their comfortable environment as possible. So we've noticed they may not mind already being home and having a longer phone call as opposed to being in the office with us longer. For whatever reason, you know, people may feel anxiety being in a setting that is medical, and so they don't want to be there a long time. So we've noticed by reducing the amount of time that they're in office with us is easier and better for them. So with every difficulty, with every challenge, I think our team has done a great job of pivoting and trying to find ways that meets our participants where they're at.
And of course, we want to have time with you to be able to answer all your questions. Some of the things that we wanted to make sure that we share with you are those recruitment strategies. What do we do? What do we do different than the usual, and how we can change things in terms of how to connect with the community. So we have these 3 questions here. We can, of course, answer all the questions, but something that we wanted to do is be able to talk to you. What are your experiences? What you've seen in the past, what you've tried in the past. And I'm going to answer the first one just so we can start. For example, what community-based recruitment strategies work? So as Alicia mentioned, we try a lot of strategies and we'll learn from those strategies. And I think the most important part of it is thinking out of the box. Like, what can we do? Listening to the community to make sure that we can recruit participants at the same time that we can create a relationship of trust with the community members. So going out to the community, to their events, something that I always find very unique about our project is that Dr. Yinka, Dr. Martha go with us. They have participated of events, and that is something that you don't see a lot as a community organization. We're always out in the community, we're always there, but not so much the researchers, and that is something that makes a huge difference. I feel like, for example, we went to like a 5K, and Dr. Yinka walked with the community, and that was something that allowed her to talk to them. And she was exercising, but at the same time sharing about what we do, sharing about what ENRxICH is, and that is something that makes a difference. So that's just one example of what we can do. Delicia is at the community, and if she knows someone, she will talk to them. She will let them know what we're doing, and people kind of like generally just ask us for flyers and ask us if they can share at their church and things like that. And it's because of that trust that they have in what we do and the way that we do things. So yeah, any questions, any comments, any experiences that you might want to share with us?
So I'll share on community-based recruitment, because my community are hospitals. So they're not individuals out living in their homes. And the recruitment strategies to recruit hospitals, that building trust with an organization takes months to create. So I always build in my studies like a good, I start working with them long before I introduce the next idea. It's what can I do to support your nursing staff? Are there presentations I can do? So that I want to be perceived as an equal partner with my organizations, and not just me coming and saying, hey, I need you to do this, but what can I do to give back? to you as an organization, I find is really critically important in my recruitment strategies.
Definitely, and as a as a nonprofit that works with both the academia, hospitals, all of that. Yes, I can rely. It's always it always takes time, and it's because something that we say is like it's like every relationship that you want to create. You want to take time. You want to meet the person first. You want to feel comfortable, and then you start to share more about your experiences, to share more and be vulnerable to being a participant, to have a partnership, to work together. That is something that definitely takes time.
Well, this is Carla Gaines. I'm with CARN, the Community Aging Academic Research Network, and Dr. Yinka, we worked together before. Dr. King is with our project now. And so as a community research specialist, I represent our African American Health Network in Dane County. And so definitely in building community-based recruitment and work, trust is definitely the key. Having someone in the community that they trust, especially involving in research trials and clinical studies, especially as a Black person, if you're trying to recruit Black individuals. We know the past history and unfortunate historical ramification and defamation of our community in studies. And the importance now of getting those that look like me involved in the work is critical and important. So having the researcher one, as you mentioned earlier, having, Dr. Yinka being out in the community, being out in those churches, going to those meetings, just not coming because you want something in return right away, but begin to build those relationships in the community is so critical and important before even the ask comes out. So I think that's key, having that trusted person to intersect with the community is key and important, because you already have built trust, and they will begin to trust you to get into that work. And bringing those researchers on to introduce them to the community is also is good. So all of your points and your work has definitely, it will be meaningful and important to community, especially those as you work in diabetes, and that definitely affects the Black population. So thank you for your presentation, and so happy to be able to be a part.
Thank you. Thank you for your comments and sharing your experience. I see some questions in the chat. Delisha, do you want to talk about the answer that you put in the chat?
Sure. So there were two questions in the chat. The first one was about the leadership of community health workers. And since we have some on our team, are we using their knowledge to be able to recruit for our team? And so the answer to that is yes. We have a new team of CHWs, and everyone isn't quite onboarded yet, but they have already in the meeting separately told us, oh, have you guys thought of this? Have you guys thought of that? Or I'm connected with. And so we're just looking forward to everyone being onboarded so we can listen to all of their recruitment strategies and connections that they have to make us stronger. So it's actually a very exciting time for us right now. And then for the second question, someone had mentioned that they're starting a research project where they'll be working with unhoused persons. And so what I had mentioned was the fact that we have done some work with City on the Hill, and they meet monthly. They always meet monthly. And we have also encountered quite a few unhoused people volunteering our time at City on the Hill in the effort of maybe some of those persons that qualify for our study can enroll. And they're such a great organization to work with. But if that didn't work out, coordinated with City on the Hill, then the next best thing that I can think of is, like, for instance, our group, we're always on a Thursday at a particular day at a particular time at one base or the another. And for the most part, our participants can count on that. So if your organization can have a base where this is where we're at this day and time, every week or every 2 weeks or every month, and you let them know ahead of time, if I lose contact with you, if you lose contact with me, if you need me, this is where I'm at, that's helpful.
Thanks, Delisha. I do want to say one thing, and Delisha, that's so helpful on a researcher perspective, because I think a lot of times people don't think about all the things you have to, when you are doing community-based recruitment and those screenings and the challenges, some of those things we've talked about. How does that impact the work you do, especially when you are the PI and you are the researcher and you have a recruitment goal, right? NIH has told you, you have to get to 300 and something people. And one of the things that I wanted to mention is my reflection on that is when we talk with our team is, oh, recruitment is not going as fast as we want it to go. And it was key for me as the PI to remind our team members is, yes, we need to meet a goal, but trust is key. And no matter what we do, we don't want to erode the trust that we've built in the community. And so I spent my time in our meetings talking about, yes, we might not be able to get it fast in terms of the sample. Really, we got to meet the sample. We got to get to the numbers. But taking the time, taking the resources to spend time in the community, to build trust with the community, even if we are not getting that recruitment outcome, the goal is we are not eroding trust, even though we are also trying to do a trial at the same time. And I think it's a key message for a lot of PIs and researchers to think about is sometimes while the research goal is key, also think about what the community goal is, which is not to erode trust and do things too fast. And then at the end of the day, you've not addressed the needs of the community, or you've not taken the time to listen and pivot. I mean, if you could ask our team members, yeah, we've pivoted a lot. We've done, we've been to not just the radio ads, for example, but we went to the movie theaters initially, if you remember at the very beginning, and it turned out that didn't work. Well, let's go back, talk to advisory board, talk to the communities. Well, you need to do this next. Well, if the community perspective is saying, let's do this, let's try that. We hadn't planned for radio ads in 2 radio stations, and we realized, wow, people are listening to us on the radio. Where's the money going to come from? Believe me, it did not come from the NIH money. As the researcher, where can we get some money to pay for radio? It seems like people want to listen to us on the radio, and then pivoting to put in that, find those resources or find those grant dollars to be able to do the recruitment the way the community is going to be very responsive. And so, and then I just wanted to mention, especially when it comes to clinical criteria, especially for individuals who do clinical trials, as you've already heard, getting people with uncontrolled diabetes in the community turned out to be a little hard, and we decided, okay, we needed to start engaging with the health systems. But it was important to think about not just any type of health system. What is the healthcare system where we can meet our community that we care about? And it turns out federally qualified health centers. So while we are engaging with health systems, we are not saying, oh, we are not going to stop our community-based approaches. Now we are going to be doing them in tandem with each other. And I think it's important to say that the community is important, but also thinking about those federally qualified health centers is key as well.
Barb had to step out, so I'm going to take over for her. Are there other questions or comments? I think I've tracked the ones in the chat.
You guys appreciate it. This is Chrissy Bartles, and I just want to say congratulations to you and your team. It seems like you really are doing the groundwork to build trust and kind of build up the avenues of the work. I just wanted to say thank you for also sharing sometimes the pitfalls or things that you tried that weren't as fruitful. So I think sometimes that's also where we can learn. So it sounded like, you know, movie theater is not so helpful. Going to health fairs where people actually were like maybe over interested in their health, or they weren't really very eligible for your project. Any other kind of things that you tried that you'd say, you know what, if I were to do this, you know, if I were to make a list of things to not bother, that you would maybe put in that bucket?
Delisha, Shari. Oh, Delisha, you're on mute if you're talking.
So one of the things I would say, I want to mention something that you didn't say, but that we found out was important. Shadi and I are representing two different demographics, Black and Hispanic. And so one of the things that we learned was that those demographics are very different on how we're recruiting and where we're getting things from. So like, for instance, with the radio ads, that's majority the Black community who has been responding very heavily to those. Every once in a while, I'll say out of 10 people, we might get a Hispanic person, but we noticed very heavily we were getting people from the Black community. We thought from the movie theater we would get the Hispanic community, but we didn't realize that at one point maybe the movie theater was successful in Hispanic community because the Hispanic community still had a movie theater in their community and it had just shut down. So it's also been thinking about the strategies of where people are naturally like congregating and what demographic is naturally congregating there. Another thing that we learned that was similar was, well, in the Black and Hispanic culture, we are very big on our food and coming together around food, and how we noticed that around holidays, we had less people wanting to join our study because we had people not wanting to make any changes to their diet. And so one of the things that we've done to not seem like the boogeyman is try to give people strategies around how can you be at important cultural gatherings like a funeral repast, a wedding, a birthday party, your own birthday party, a holiday, and still be able to be with your family and have that important meal without feeling like my diabetes is taken away from my culture and my connection. And then far as like things that I would say we truly had to pivot away from and probably won't go back. The first one is any event or festival where people are partying. We just know that's not going to work out. If people are dancing, they don't want to hear about their health, because again, that's also connected to their food and other things like that. Events where you may see the same people over and over and over again. So like, for instance, just because you had a good partnership with an organization, we learned that with a few organizations, like, okay, we have a good partnership with them, they're great, but those partnerships bring the same people every event, and those people may want to do their A1C for the second, third, fourth time. And it's like, no, the A1C lasts for 3 months. We don't need to check it again. And then it ended up being like an oversaturation. So I would caution against, like, just because you have a good relationship with an organization, maybe not, you know, unless the people will change. Like, for instance, the Mexican consulate, we get different people. But when we were at McGovern Senior Center, we weren't. We were also starting to notice that with City on the Hill. So it's like, okay, we have to space out when we go there so we can make sure at least 3 or more months have passed, so that if someone tries to come again, at least they're eligible to get their A1C checked. Other than that, a pivot that we're doing that I think is important is when you're at an outdoor fair, even when it's educational, if they have some type of like passport where it's like sign off or stamp that you went there, those haven't been successful for us either, because you have to spend some time interacting and talking with us, and people are like, I just need you to sign off so I can go to the next one and get my prize. So for us, those weren't very fruitful, because we need you to actually spend some time with us to talk about your health. And when you're at a fair where the goal is to get as many signatures as you can, those didn't quite work out for us either. So I hope that answered your question.
And I just want to add quickly, something that we learned from those type of experiences where people are not engaging in conversations with us is that we need to first establish a good understanding of our project from their leaders. When we went to churches, things like that, if the pastor, if the leader understood, oh, this is important, this is something that will benefit the community, they will talk to people and they will bring the people to us. And that will allow us to talk to them about the study without the rush. And I feel that that is something that we're going to be implementing in terms of, okay, when we go to a specific event or a church or a place or a different type of space, it will be important to have that person that will talk to people about what we're doing. And that's what's happening at the Mexican consulate, as Alicia mentioned. They're go and talk to people and let them know the team is there and that's what they're doing, and this is important because of this, this, and that, and how it impacts our community. And that creates that environment where we can talk to people.
Thanks for those fabulous examples. Those are great.
Yeah, thank you. Thank you for this whole presentation and discussion. And something I'd like to call out that I don't think you all have given yourselves the credit of naming, but the key to so many aspects of successful and respectful recruitment is, and as you've demonstrated, really good critical thinking, being adaptable, and being humble in your approach. And so, yeah, I just appreciate the care and thought and humility with which you've obviously been able to pivot successfully and learn from things that don't work so well, and hopefully enjoy the process as well. Yeah, so I welcome anybody to share any last thoughts or from our excellent preventers, Delisha, Sherry, and Yinka. Thank you so much. We will send out, in addition to, Kathy just put a link in the chat to an evaluation survey, which we would be very grateful if you would complete. It's really helpful to us, and we share it with the presenters. So we would appreciate that. And then, as Barb mentioned at the top, this is a monthly seminar. Oh, there we go. Kathy's anticipating my brain. So please join us next month on Valentine's Day for another excellent presentation. And so with that, I'll stay on if there are any other final thoughts or questions. But I hope everybody stays warm and safe. I understand there's been some crazy traffic issues in Madison, so I hope you're all safe and comfortable and where you need to be.